Hello. Hello. I am Sudhanshu Patwardhan, guest editor of the Drugs and Alcohol Today's special issue on 15 years of FCTC and part of the organizing team of this unique multi-stakeholder virtual global event, the 15 Years Conference. Welcome to the second day of the conference. The World Health Organization's Framework Convention on Tobacco Control, FCTC, came into force 15 years ago and made great strides in achieving process outcomes in tobacco control globally, ensuring policies got rolled out and incorporated into national laws. However, marketing and sale of risky forms of tobacco continues with practically little regulation or enforcement in many parts of the world. Consumers continue to be stigmatized as addicts without any meaningful support to sustainably quit smoking, or in the case of South Asia, smokeless tobacco. With over 1 billion users of risky tobacco globally, 80% of who reside in low and middle income countries, tobacco use continues to widen the socioeconomic and health divide between countries, subpopulations, and gender. In this conference, we are attempting to bring to the fore these issues that have been neglected throughout the past 15 years of the implementation of the FCTC. We hope to create a constructive platform to discuss and agree on next steps in accelerating the positive public health impact envisioned at the conception of the treaty. Yesterday, Dr. Axel Klein and the panel covered a range of topics from neglect, stigma, low investment in research in the global south in tobacco control, to development and alternative livelihood issues within the tobacco supply chain. Today's panel is equally impressive in its breadth of global policy, regulation, science, and healthcare experience and expertise. We need to hear from them and those watching live from around the world on how we can accelerate our progress in reducing the harms from tobacco globally. So a warm welcome to you all again. May I start with Professor Jed Rose from Duke University and the CEO of Rose Research Center, co-inventor of the nicotine patch and an expert on the science of nicotine. Jed, welcome.
Thank you. Pleasure to be part of the panel.
Thanks, Jed. From your experience of decades in this field, what are the best rates achievable for quitting at 3 months, after 1 year? How are these achieved? And what happens to those who fail?
That's a very good question. And one can, first of all, divide the categories of quit smoking aids into two main categories, behavioral approaches on the one hand and pharmacologic treatment approaches on the other. Behavioral approaches are effective, but most smokers have not availed themselves of behavioral approaches because of the need to visit group or individual counseling and the time and effort required. Perhaps later we can get into how perhaps smartphone and other technologies can make such treatments more widely available. In terms of pharmacologic treatments, there are essentially 3 categories that have been used and approved by different regulatory agencies. The oldest being nicotine replacement therapy, where nicotine is provided to the smoker in the form of either patch gum, lozenge, nasal spray, and so forth, to relieve the withdrawal symptoms of smoking and make it easier to relinquish cigarettes. The second category is bupropion, which in the US is marketed as Zyban. And that has effects on neurotransmitters in the brain. It was originally an antidepressant, but may also interfere with some of the actions of nicotine to make cigarettes less rewarding to smokers and also alleviate withdrawal symptoms. And then the last category varenicline, as an example of, is what is known as a partial agonist at the receptor. So it does relieve withdrawal by stimulating the same receptors that nicotine from smoke would, but it also blocks some of the rewarding actions of smoking, making cigarettes less appealing. Right now, varenicline is the most efficacious single medicine. And with any of these treatments, one can expect to achieve rates of up to 40 or 50% abstinence at the end of, let's say, a 12-week course of treatment. However, and the big but is that when treatment stops, there is an inexorable relapse curve, so that when you look out at 6 months or a year or later, one is lucky to see even 10 or 20% of smokers remaining smoke-free at that point, a year or more out. So, so we are desperately in need for more innovation and more long-term efficacy. And in that regard, an important point is that electronic cigarettes and other non-combustible forms of nicotine replacement that are suitable for long-term administration could potentially be important to allow a smoker to transfer their nicotine dependency from the most lethal form, cigarettes, to a form that does not deliver the cancer-causing and other harmful components of smoking. So there may be an avenue to prolong abstinence beyond the usual 12-week treatment window with such technologies, and I'm sure we'll discuss that further as well.
Jed, thank you so much for the opening statement, and that contextualizes the challenges in regards to the ability or the inability, in fact, of most of the smokers out there, and that's billion plus people out there in the world who struggle to quit despite availability of medications which work, as you said, up to 12 weeks or so, but then the success rates dramatically decline, and relapse becomes one of the biggest issues in smoking cessation, effectively. And you touched upon some of the products, which we will definitely discuss later. But that brings us to the next panelist I want to really query, because this is around the concept of the products you mentioned. They are expected to be reduced risk products. The phrase harm reduction is often bandied about in this context. May I ask Dr. Derek Yak from the Foundation for a Smoke-Free World. Derek, you were one of the key architects of the FCTC. We were gently reminded by one of the panelists yesterday of the definition of tobacco control as per the FCTC that includes demand reduction, supply reduction, and harm reduction strategies. What did the WHO team mean by harm reduction strategies when you wrote it?
Thanks, Sid, and wonderful to join such an amazing panel and all of you watching around the world. Let me just go back to that period and try and think about the late 1990s, what we knew, what we were talking about, because that was what drove us to include harm reduction in the definition. So a decade before, Jed and Michael Russell on the other side of the Atlantic had actually already started the first harm reduction products. Jed with the patch, Michael Russell with the gum. They had separated nicotine from the stuff that kills you, and they knew that if they were able to have nicotine provided to the smoker, there was a high probability that many would be able to switch to a lower risk. That was really the start, and we were very aware of that literature. Remember that by 1998, the court cases in America had started disclosing the data of what the industry knew decades before about nicotine and harm reduction, and their very high level of experimentation in trying to actually produce a reduced risk product. We had the start of low tar. We had a range of experiments in light cigarettes, which were on the market. Many in the tobacco control world embraced those as being potentially reduced risk products. It turned out we were wrong. We were all wrong about that one. But the mindset going into the start of the development of the Framework Convention, which was in 1998, believe it or not, 22 years ago, was that there probably was advanced science held by the tobacco industry that we needed to understand before we actually even started the negotiations. So in the year before the formal negotiations started, we held meetings in WHO headquarters where we invited the tobacco industry scientists to present what they believed would be the potential route for harm reduction and what was on the menu. Unfortunately, it was a fairly meager menu at the time, and I don't think they used the chance to really present what was truly going on inside their laboratories. I think we would have had a richer debate. But that was the start of getting a hint of what was coming, and people were seeing the pharmaceutical industry was also innovating. So it seemed pretty sensible to us and our early Tobacco Products Regulation Committee, chaired by Richard Hurt from the Mayo Clinic, that harm reduction would be a potential enormous gain to bringing the death rates down, and we needed to include it in the very definition. The last comment I'd say about context, because it really is important, in tobacco control, since then, people have gone off on their own, delinked from harm reduction in the rest of public health. Well, the 90s was the period of intense discussion around harm reduction to bring the death rates from HIV/AIDS down, and it was seen as completely natural that harm reduction would be an inbuilt feature of any public health strategy for HIV/AIDS. Looking at tobacco, we saw the analogies and believed we could build upon it. So to summarize, the history at the time, the scientific evidence at the time, the hints of potential progress, the potential gains for public health were all there. It was obvious that we were going to put harm reduction into the definition.
Derek, thank you so much for that insight on the introduction of the word and the logic behind it. I'm going to change gears slightly and move to Patricia for a very specific reason. Patricia Kovacevic, as a lawyer and expert with years of experience in engaging with regulators globally, including with the US FDA, and your experience from around the world, I want to ask a specific question about what hurdles over the last 2 decades, what hurdles did the implementation of the FCTC face in the developing world, from companies as well as from lack of local institutional capacity, and whether there is any room for further increase in using regulatory tools such as tax in low and middle income countries to disincentivize smokers from smoking. I know this is a very specific set of questions, but this is just to make sure that when we talk about FCTC's various demand, supply, and harm reduction strategies, we have understood what's been done so far and what are the challenges already being faced in a big part of the world. So Patricia, please.
Thank you, Sud, and thank you for this amazing opportunity to join this distinguished panel of experts. Thank you for those who are watching. Indeed, the biggest challenges in the implementation of the FCTC, I think, are certainly in countries where 2 main issues arise. First and foremost, some of the countries, have a symbiotic relationship with industry, if you wish, partly because, a great deal of the country's revenue depends on taxation. A great deal of the country's employment may depend on employment in the supply chain of the industry, but also because of lack of enforcement capability. It is true that the FCTC creates a framework, but unlike more prescriptive legal instruments, such as, for instance, the directives in the European Union or the regulations of the European Union, an international treaty is just that. Of course, it lays the foundation for what the national laws should look like. But ultimately, there is a great deal of discretion at national level as to how fast, how exactly those principles are transposed into laws on the book. And furthermore, even when you do have very strict laws on the books, the question follows, are those laws in fact enforced? And certainly you need resources for enforcement. So between somewhat interdependency with the supply chain to the industry and the industry itself, the fact that countries don't necessarily have public health, yes, it is a priority, but in many countries there are other issues of public health, things as simple as clean drinking water or vaccines that somewhat take precedence. They seem more urgent. You know, their results of those health crises are much more immediate. The fact that even you know, more well-to-do countries, you know, maybe medium-income countries may have resources but not enough. Certainly, we haven't seen the same level of implementation of certain measures and the same rates of success. You can overlay the cultural background of every country. Of course, in some countries, smoking is much more culturally and socially acceptable. It's more traditional. There could be perhaps a strong leaf growing industry. All of those things create a very multifaceted, a very big, broad picture with a lot of details. You cannot really pinpoint one single reason why a FCTC implementation is not successful. It's usually a myriad of reasons in any particular country, and every country will be different. But where it all starts, it's certainly the political commitment and the political and social will to address that. You mentioned taxation as one of the tools that can be deployed, and as you know, together with a couple of colleagues, we wrote a paper discussing various government measures that regulate, for instance, the market for novel tobacco harm reduction products, and evaluating the public health impact of excise taxes levied on these products as an incentive, or I should say comparative excise taxes that could basically coerce or at least disincentivize the use of the more harmful products. Of course, I would strongly invite you to read the paper. However, taxation is, again, just one of the elements, and there is a tipping point above which taxes really only drive a stronger black market. And at the same time, if you don't have differential taxation that communicates the harm reduction differential among different products, you know, you're sending the wrong message. So because since the FCTC, so many new products have come on the market, some of which are clearly and scientifically proven to be reduced risk or reduced exposure, certainly it wouldn't be appropriate to suggest that every single nicotine-containing product that may be called or classified as a tobacco product should be, you know, taxed at the same level. So there is a lag, if you wish, or a delay between the market forces, the products that come to market, the risk perception among consumers, even among regulators, by the way, and you know, how the FCTC tools are deployed. Are they fine-tuned to reflect the market realities? And I would say probably not. And I think that's one of the biggest challenges of FCTC implementation, frankly, in all markets.
Wow, Patricia, thank you so much for really taking us on a whirlwind tour of the various regulatory challenges from around the world and introducing very key concepts, talking about market realities, cultural specific issues, all the way to differential tax and what message is sent to consumers. So I'm going to use that to then go to the next panelist because we are now keen to ensure that the conversation is very consumer centric. At the end of the day, we're talking about 1 billion plus people using risky forms of tobacco around the world and helping them quit, even those motivated to quit, as we all know, is not easy. So who knows this better than Professor Riccardo Poloza, respiratory physician, and the first to set up a smoking cessation clinic in Sicily, Italy. Riccardo, from your experience with smokers in Sicily, and there's a lot of them even now, what seems to work for smokers to quit? Products, advice, support, all of the above? Can you please tell us more from your experience, please?
First of all, thank you very much for having me, and hope all the audience all around the world is enjoying this panel. It is true that we are here to celebrate the 15 years of the FCTC, but let me play in relation to your question the devil's advocate. As a clinician and as a cessation expert, the FCTC has failed a big deal on one of its major pillars, being the cessation. The cessation aspect failed for two main reasons, and then we'll talk about the consumers. One reason is the use of drugs to counteract nicotine dependence has never been subsidized to a certain extent, and smokers do not like to label themselves as patients that they need to be medicalized. And the second problem with the FCTC in relation to cessation is the failure to understand the psychology of the smokers. Smokers want to quit without quitting cigarettes. That's a fact. That's what more than 20 years in clinical practice has taught me. People do not want to have the risk associated with the cigarette, but they still love to handle it, to enjoy it socially, to share the cigarettes with their coffee and with their friends. So this explains to a big deal the disconnect that Jed was talking about the data from randomized controlled trials. And as you know, randomized controlled trials are run under very rigorous rules, and most of these people are actually paid for these trials. So it comes to no surprise that by the end of the trial, many people will relapse back to smoking because most of the motivation has gone, and the proposition, the value proposition for smokers is still there. I found extremely difficult to work with smokers, and it's a very frustrating job. And the main reason is, as I said before, smokers do not like to be medicalized. They don't really want to pay for their medication. And that's the reason why I become so passionate about alternatives like electronic cigarettes, because it's a tool that allows to deliver nicotine by keeping the ritualistic aspect of smoking, to which smokers are so passionate about for a number of reasons. Okay, and I think this is a very important point that needs to be acknowledged, and that's one of the most important points that goes overlooked when we are having discussion about tobacco harm reduction and about cessation strategies and so forth. So I'm very glad that early in the year 2000s, there were these discoveries that they were bringing new tools, that they were delivered, let's say, some clean form of nicotine to people in dire need of their nicotine fix, but without the toxicity of combustible smoke.
Ricardo, thank you so much for a medical doctor's perspective, but with your experience with smokers and in cessation, that brings such a rich understanding of the challenges in what people around the world have faced and continue to face, which means that we need a lot of solutions well thought through, and back to some of the earlier points mentioned, culture specific, context specific as well. So I really thank the panel for the first round of introductory sort of thoughts and remarks. Let me just acknowledge that we have a lot of questions coming through in the Q&A panel of the live chat. So I am gonna make an effort to get all of those questions passed on to the panel in the next 1 hour that we still have, and ensure that we get great inputs from the panel and have a good, robust conversation around that. Let me also take the opportunity to remind all viewers to check out, if they haven't already, check out all the articles that were published in the special issue of the Drugs and Alcohol Today journal. These are available on the conference website at www.15yearsconference.net, and the accompanying video interviews of these authors, including some on the panel today, and beautiful graphics summarizing the key findings of those papers, which will no doubt be insightful and thought-provoking. Derek, your paper on accelerating an end to smoking had a very powerful graphic. Can you please talk us through your thinking and the scientific basis on such dramatic alternative scenarios that you've painted there and are part of the graphic, and the urgency of action needed, please?
Sure, thanks, Ricardo. And I think, I don't know if the graphic is going to be viewable.
Yeah, we plan to put the graphic online, so it should be coming on screen in the next few seconds. There we go.
Yeah, okay, thank you. So I'm really thrilled to have a chance to explain this, and I'll try to keep it very brief and very simple. I feel that there are issues embedded in this that most people who claim they're involved in tobacco control have no clue about. And it really boils down to one biological reality. There is a lag of decades between the time you start to smoke and the time you start to see the diseases associated with smoking. That lag can be 20 to 30 years for lung cancer, 30 to 40 years for chronic lung disease, but shorter for heart disease, anywhere from 10 to 15 years. So just remember that, decades when you start and when you start seeing the outcomes. So if you look at the curve, you will see that today we have 8 million deaths, likely to rise to 10 million, based on WHO estimates, and assuming that the full implementation of the Framework Convention, according to WHO, is followed. So why are we going to have increased deaths while this is being implemented? The reason is because the risks have accumulated in your body, and even if smokers were to stop today, they would continue to die at higher rates for the next few years. Point is that it makes a couple of very important issues. First of all, the impact of interventions takes time to have population effects. That's very different from the time it takes within the clinic. So Ricardo will tell you he can see some benefits accruing in his patients pretty quickly. At a population level, you don't. It takes a very long time. The policymakers tend to think that if we put in place all the provisions that stop kids starting, for example, we would have an impact on the curves that you're looking at. In fact, you won't. You will have virtually no effect. If not a single child started smoking or vaping today, the impact on mortality for the next 40 to 45 years would be virtually zero. The reason is because it takes that amount of time to start seeing the impact on death and disease. If our interest is in acting in the relative short term, and for tobacco, short term means 10 to 15 years, the only way to bring the death rates down, the only way, is to focus on better cessation, but getting us to levels beyond those that Jed said are the reality today, and providing harm reduction that's accessible and widely available. Those combinations in today's adult smokers, we estimate, could bring the death rates down by well over 3 million per year, multiplying up to tens of millions of deaths. A couple of other points to remember: that it's not only tobacco harm reduction and cessation that will bring the death rates down. Think over the course of the next few decades. We are already seeing profound improvements in early diagnostics for the biggest cause of cancer death caused by tobacco, lung cancer. If we bring the lung cancer diagnostics down from where they are today to early stage where they might become treatable, that would also have an impact on the death rates. And better treatments are also coming on stream. So what I want people to look at is that the green line, the line of where I believe we should be, is a combination of us assuming that harm reduction of efforts today become available on a widespread basis, that cessation today is available, but over the next decade, we improve the efficacy of cessation products to double, triple, or even quadruple the efficacy and the effectiveness in the field, and that better treatment of the outcomes improves. Final point I'd say is the other reason why this graphic is so important is it reminds us what the purpose of tobacco control is. The purpose is not only to focus on the prevalence of smoking or smokeless tobacco use. The purpose is to focus on reducing deaths and disease in real people over time. And that is a gap that we tend to forget. It's about less lung cancer, oral cancer, chronic obstructive airways disease, heart disease, tuberculosis. And to get there, we're going to have to combine our best of science on harm reduction, cessation, better diagnostics, and better treatment. That means more involvement of clinicians, more involvement of people in the laboratory sciences, and certainly a greater focus on urgency.
Derek, thank you so much for talking us through that graph. It is indeed very powerful. And if I was to say that such modeling and such data in this graphical form should be on the essential reading list for medical students and professionals in clinical medicine and public health, and indeed everyone globally. That brings
so
me
can I add one short comment, possible? Sorry.
Please.
I think I would want those watching also to be aware that there have been really excellent recent modeling exercises, both on the theory and practice. People like Ken Warner and David Abrams, Ray Niora, actually with a group of tobacco industry scientists, have put out models. To my mind, the most important question we have to ask ourselves is, these models make assumptions about the future. We're living in this COVID-19 pandemic when models are thrown at us every day with wild assumptions. These models actually only require us to solidify one assumption. We know what happens to smokers when they quit. We know that with great certainty based on 60 years of epidemiology. We know, for example, that smokers who start young will have a worse outcome. We know that smokers who quit before the age of 40 actually recover almost their life expectancy that they would have lost if they had never smoked. That's never spoken about enough, based on massive studies. We know what happens if you quit. So what do we not know? We know that harm reduction products dramatically drop your exposure. What we don't yet know is, if you have a 95% drop in exposure, how does it translate in terms of death and disease? Is it going to be 95%, 85, 75, or 65? And when I did those, let's call them thumbsuck models of the numbers, I assumed 65%. It's probably going to be higher than that. That is the single bit of missing evidence that once we have it, we will have great certainty about the potential of harm reduction to cut the death rates fast.
That's a very, very important point in kind of putting some context to how you've arrived to those graphs, and also how some exciting work is already happening in the academic public health, but also the industry, to come up with these models and be able to give us a better grip on what may be achievable if there is a multi-stakeholder collaborative effort to get there. I was going to use this example of this essential reading, as I said, to segue into another essential list that is often not understood, and also leads to a lot of issues in embracing cessation.
I'm sorry to interject very quickly, but I very much like to reinforce what Derek said. Mm-hmm. The beauty of these alternatives is that they are very popular in that exactly age range of interest where we can reverse the risk to a great extent. So whereas all these smoking cessation drugs have been used by people over the age of 45, 50, or 60, these alternatives, combustion-free nicotine delivery products, are very popular amongst age 20, 30, 40. That's exactly where we need to have an impact. And that's probably where we are going to see the most advantage in the next 10, 15 years.
I totally agree, Ricardo. In fact, why don't we use this to go around the panel? And I think maybe ask views from Jed and Patricia if you want to add something to this conversation with the modeling data in mind, but also the kind of age groups Ricardo mentioned just now, and what are the challenges they face what are the hurdles they may have in terms of being able to quit sustainably?
Well, I'd like to amplify a couple points, and I think the point about quitting before the age of 40 is one which I now routinely mention in every talk because it does not get enough attention. I wholeheartedly agree with that. And in terms of coming back to Ricardo's very important point about the importance of ritual and the ritual of smoking, to which I would add, and our research has shown there are a lot of sensory effects, the taste, the smell, the feeling of inhaling smoke, that smokers become as addicted to as they do to the nicotine getting to their brain. A couple of studies among many, Dr. Neil Benowitz, a leader in the field, showed years ago that even if you applied 3 nicotine patches to smokers, they still smoked over half as much as they would have anyway. In my own research, we have administered nicotine intravenously at the same rate that a smoker would get by inhalation, and they go on smoking as much, almost as much as they would anyway. So the analogy that I often like to draw is that of eating a meal, which is far more enjoyable than getting intravenous feeding, for example. So it's more than getting the nutrients, the chemicals into the body. The brain has learned to enjoy the stimuli associated with the act of ingestion or the act of consuming the substance, in this case, smoking the tobacco. And that's why I think the methods of cessation that do replace those habit components have tremendous promise for improving success rates in the long term in the future.
Thank you, Jed.
And Jed, to that point, it is very important to highlight the fact that Carl Fagerström has actually changed the name of his questionnaire and test from a nicotine dependence test to cigarette dependence test.
Exactly.
If I may join Ricardo and Jed in praising the effectiveness of the slide that we just saw, and also how important it is to put things into perspective and to realize the different trajectories with or without the intervention of acceptably or consumer acceptable harm reduction products. The most important thing is, first of all, that this slide be communicated to governments. And the even more important thing is that even 20 years from now, when science will have, in my mind, undoubtedly proven that a reducing exposure in a product leads to long-term comparative health benefits versus just carrying on smoking. The important thing is that those findings also find their way into the regulation, that are also communicated proactively by the government and not just by the industry and academics, because we all talk in an echo chamber most often than not, and we don't speak the language of consumers. This information is most reliably conveyed, or should be most reliably conveyed, by governments. And in some cases, it's those very governments that, in fact, I'm sorry to say, but mislead consumers by communicating that even a very small amount of something will still have, tremendous consequences, as if zero risk in our lives were in fact possible. That's where I think the biggest challenge lays. Even when the science will have proven this point, that point still needs to be communicated by those who are responsible ultimately of public health, which ultimately are our governments. That's something where we can and should start working on right now. Otherwise, these studies are just going to be very, well communicated in academic publications, conferences such as this one, perhaps, the industry in those places where they may be able to communicate comparative risk, they will, but the vast majority of consumers will not know, and they might make the wrong choice in continuing to use the most harmful products because they do not see or they do not foresee a health benefit.
Patricia, that's great input, and I think I'm going to use that to specifically ask Jed and then Derek and then Ricardo on a specific component of tobacco products and how it is perceived by a lot of people out there, in fact, everyone. And so that may be a clue to Jed on a part of what we published in the paper in the special issue regarding nicotine misperceptions. And my question for you, Jed, is this, that we talk about this in the paper. Is this phenomena global? And how does it matter when it comes to cessation support and relapse prevention?
Yes, this is a really vital issue, and in a publication that you published of a study in India and in other studies in the UK and in the United States, it's clear that there is enormous misconception about nicotine, where over half of physicians think that nicotine causes cancer, and the evidence clearly shows that nicotine is not a source of cancer in smokers. For example, the experience in Sweden with the smokeless tobacco product snus, they don't get cancer. They have the lowest rates of cancer in Europe, and yet they receive full doses of nicotine through this smokeless product. So how is it that there is such a widespread worldwide misconception that blames nicotine instead of the actual villains, which are the products of burning tobacco? And I think there is a very strong cognitive bias that results from two sources. And they both, in a way, reflect the same kind of conditioning process in the brain that we were talking about when we were talking about how the ritual of smoking becomes embedded in the pleasures of nicotine and the whole habit and addiction. And that is by a sort of Pavlovian conditioning. So in this case, nicotine has been associated with tobacco for decades until the recent years, where it has been separated, as Derek mentioned, with pharmaceuticals like nicotine patch and gum. But historically, nicotine has always been bound up in tobacco, which does cause disease. And so there's that learned association in people's minds and their brains between nicotine and disease. And then the second source of the bias, I think, is the association of nicotine with the tobacco industry, which has, in some cases, been deceptive and hidden the truth about the dangers of smoking. So because of this, many people in the tobacco control arena have a conscious or unconscious bias that actually filters data in a very unfair, biased fashion. For example, there have now been several clinical trials showing that electronic cigarettes do help people to relinquish smoking, combustible cigarettes. A study by Hayek et al. In England showed that e-cigarettes were actually more effective than state-of-the-art nicotine replacement therapy at 1 year. And there have been other clinical trials also showing that e-cigarettes are at least as effective, if not more so, than conventional medicinal nicotine replacement. And why wouldn't they be? After all, every form of nicotine replacement that has ever been evaluated in clinical trials, whether it be gum, inhaler, nasal spray, patch, and so forth, have all shown some degree of efficacy. So in that context, it is really amazing. And I have heard very reputable colleagues deny that e-cigarettes help people quit smoking, or say that, well, it's so unknown that we just have to wait for much more evidence, which to me shows a very strong bias to filter evidence through a particular lens that I think goes back to the historical associations between nicotine and the thing that actually does cause the disease, cigarettes, and nicotine and the tobacco industry. And if people can examine their beliefs more scientifically and objectively and really focus on the evidence in a fair way, I think they would come to the obvious conclusion, which is that these things, these non-combustible forms of nicotine, can be extremely helpful in producing the kind of immediate benefits that Derek is talking about in terms of public health around the world.
Well, thank you, Jed. I'm going to then just ask Derek, because one of the papers published in the special issue was written by members of the Foundation for a Smoke-Free World, and this was the perceptions of nicotine in current and former users of tobacco and tobacco harm reduction products from 7 countries. That's a massive survey. Now, Derek, would you mind just talking us through the driver for doing this, but also what do the findings mean in terms of what needs to be done as a priority?
Well, I think Jed has really highlighted the challenge, and we felt that sitting at the core of the of success in tobacco control is our understanding of nicotine, or the misunderstanding of nicotine. And it's an incredible privilege for us to actually have Jed, who sat at the beginning of the use of nicotine for good. Nobody doubts that. Everybody asked whether nicotine in a patch or gum is a good thing. We'll say, yes, it is. But when the delivery device is shifted and it's the same nicotine and it's sitting in an e-cigarette or an IQOS or snus, it suddenly becomes toxic because, as he explained, people have confused, often rightly, the inability to separate the nicotine from the other stuff in those products. So we wanted to test it. And the single most important differentiating question, we believe, is, do you believe that nicotine is the major cause of cancer? And the results are alarming. They show very high levels of belief across all of the countries. And we've seen that some of that has hardened over the last few years because we've repeated it now over the last 2 years. And it speaks to the fact that there is considerable doubt driven explicitly and deliberately designed by a campaign run by Bloomberg Philanthropies through the Campaign for Tobacco 3 Kids, through the union, reaching into NGOs and media around the world, explicitly trying to sow doubt about the damaging effects of nicotine on children's brains and on adults, none of which, of course, is supported by the science. So it's not just a general view out there, it's a propagated view, deliberately propagated with a particular goal in mind, namely to stop kids vaping, which is a laudable reason. But doing it at the cost of confusing adult smokers who try to save their lives by getting off a damaging product is simply unethical and behavior that should not be tolerated. The last comment I'd say, and the reason why we did these surveys, is you can say, so what is next? It's one thing to quantify and know. The other is to intervene and act. And that is where we want to go. And we believe that the work you did in India, colleagues done in the US, showing that doctors have as bad knowledge about nicotine as the general population, is the clue to where we've got to go. As you know, I believe very strongly that we never make progress on tobacco control without having the doctors in the lead with their voice and leadership. In this case, that would not be a good thing until they understand what the true science is. So step one must be to engage doctors around the world with the true science. Let them understand the benefits of nicotine in the smoker. And then when they start speaking out, we'll see the policy environment change, as well as they'll be able to influence their patients.
Derek, thank you so much. In fact, as I look at the questions coming through, I think it's perhaps the best time to start introducing them. In fact, you answered, between you and Jed, you answered one of the questions that was asked, but I'm going to read it out so that our audience know that we're listening to them, but also want to respond to them. So Andrew Thompson asked specifically for Jed, but I think, Derek, you answered the question, which is, should tobacco control folks be blamed for maintaining the nicotine harm misconception? And I think, Derek, you answered that in great detail. Another question from Norbert Zillatron Schmidt is, did the tobacco company heads really lie when they claimed that nicotine is not addictive? Please note, they did not say smoking. This is the question that's come through. I would like the panel to respond to this because we want to make sure that we send a clear message about nicotine's role in addiction versus its harms in terms of smoking-related diseases. So who wants to take it on?
I would like to offer one initial comment about that, which is that it is well known from studying addictive drugs in general, whether it be heroin, morphine, cocaine, amphetamine, and so forth, that the addictiveness of a drug is highly dependent on the route of administration and the rapidity with which it reaches the brain. So, for example, nicotine in the form of a nicotine patch delivery system has a very low addiction liability. But whereas inhaled nicotine in the form of cigarette smoke is highly addictive. So whereas it's valid to point out that the degree of addiction of a drug is not just a characteristic of the drug, but rather also a characteristic of its route of delivery and speed of delivery, as well as the genetic and other individual constitution of the person and their own vulnerability to addiction. Still, in all, I think one would have to say that nicotine is an addictive drug because it has the potential, when delivered in an appropriate vehicle, to addict a fairly high percentage of its users.
Thank you, Jed. Does anyone else want to comment on that? Or we can move to the next question.
I'm not sure if I'm going to make a specific comment to that question, but in relation to addictiveness of nicotine, let's get this clear. Do we really want an alternative to tobacco smoke? Yes. If that is the case, we just need the nicotine to be delivered more or less in the same efficacious way as the combustible cigarette does. As simple as that. Let me go back for one single second to what Jed was mentioning about Peter Hajek's study that was published last year in the New England Journal of Medicine, and the results. The results were that by the end of the study, at 1 year, 18% of those who switched to electronic cigarettes were basically abstaining from smoking. And now let's jump back in history to our first randomized control trial, the ECLAT study in 2013, which then used very poor quality electronic cigarettes that were not even delivering enough nicotine at that time. And let's review the quit rate of those products. It is 6% at 1 year. To us, that was an incredibly good result because we were working with people who didn't intend to quit in the first place. So a 6% for us was a good result. But in historical perspective, with Peter Hajek, this is basically a threefold improvement in quit rates. Now the question, what if we use in the next randomized control trial a super Juul, a super IQOS? I'm sure, I bet my life, that we will see 38% quit rate at 1 year in the next study. So innovation matters. Innovation matters because we will be able to keep enough nicotine in the system of people needing that level of nicotine by also maintaining that ritualistic aspect that Jed was talking about. And I'm adding the flavorings, I'm adding the puffing experience, having something in your fingers, gesticulating. So this is all very important. So addictiveness is a price to pay if you want to have proper cessation.
Ricardo, thank you so much. I'm noting a few words which are coming up in the conversation. Addictiveness, of course. There was earlier a mention of affordability, Ricardo, in your experience from Sicily about how alternative products need to be affordable. And there's a question that's come through the Q&A, which is from Richard Pruen. And I would first point it to Patricia, please, and then we can go around the panel. Harm-reduced products such as vaping work best when the market supports them as a cheaper option. Surely this is a better intervention than sky-high taxes and the resulting black markets. What would be your response to that, Patricia?
Absolutely. Thank you for the question. It actually comes in a very timely fashion. So in fact, the paper that we published in Drugs and Alcohol Today modeled, lives saved if there was a appropriate level of taxation, basically, and also communication of ends benefits to public over a period of time. In fact, applying various evidences and modeling, there could have been really millions of lives saved only if smokers were given the opportunity and communicated the opportunity to make quit attempts with vaping products, and that needs to be communicated again in a way that is both commercially sound, meaning by using differentiated taxation and bringing these products, the end products, as a price point that is in fact acceptable and affordable, and provides an incentive to switch, but also communication of the comparative benefits of those products. More importantly, when we're talking about taxation, we've seen already in some states, for instance, in the United States, Minnesota and others, where unreasonable levels of taxations were introduced that certainly it killed the market. Not only from a consumer point of view, obviously from a manufacturer and distributor point of view as well. Ricardo mentioned flavors. I don't think taxation is the only incentive or the only benefit to smokers. Enjoyment is something that, interestingly enough, governments don't necessarily put a price on, and they should. Enjoyment means quality of life. It means, it's not only about going through the motions of being alive, but also having the freedoms to enjoy what you want to enjoy. And in fact, we've seen that with the lockdowns just recently, of course, that caused a lot of damage. And we can look at things like flavor bans or unreasonably high taxes that, in fact, don't allow consumers to accede to a certain product as barriers to that enjoyment, that freedom of enjoyment, that freedom of choice, which again, I don't think it's appropriately reflected or even considered by lawmakers and regulators as an important element of the whole, formula of harm reduction. And that should be very important. One more word about taxation. Ideally, in an ideal world, a product that has a designation of reduced risk or reduced exposure should by default be placed in a different bucket than the most harmful products. And in fact, we see that there is a very vague attempt to do that in one of the states in the US by taxing in a differentiated manner products that have received a modified risk or modified exposure finding from the FDA. But the reality is that worldwide, there is no such mechanism. And in fact, there is not even a mechanism to communicate comparative risk legally in the vast majority of the world.
No, thank you, Patricia. Derek, you want to comment on that, please?
Yeah, I just want to build on what Patricia's saying. I think that this notion of regulating proportionate to risk or benefit is fundamental to how we think about the regulatory framework going ahead. And I think we need to remind policymakers that this is not unusual. It was how we got lead out of gasoline. It was how we're encouraging solar panels on your roof. It's how we're getting people to shift to hybrids and reduced exposure cars and so on. So it's not unusual. The important thing, though, is to remember that it's not just about price differential, which is usually the number one. But I would say that there are four essential components of what we need to think about when we regulate proportion to risk. Price, and using the tax structure being one of the most easy and powerful means. A differential will drive change. Flavor is the second one. And I think the current example of the European Commission banning menthol in combustible cigarettes, keeping them in heated tobacco products, e-cigarettes, and in gum, is a natural experiment which we have to evaluate. Will the menthol cigarette user be switching to those reduced risk products or go to a non-flavored cigarette? The implications are important. Watch our space, because we have studies in the field from before the ban till after the ban, and we should be able to report by the end of the year. Thirdly, nicotine levels also need to be part of the regulating proportion to risk. And I think there's a serious reason to have a discussion around at what rate and how do you start lowering the levels of nicotine in combustibles while maintaining them in the harm reduction products as a third means to differentiate in the regulatory framework. And finally, the one that Patricia hinted at as well, the information environment, the ability to communicate. We have some countries in the world which have regressed on this. So in Israel, the plain packaging law, which just came into effect recently, doesn't allow a consumer to distinguish from the packaging whether a heated tobacco product, an e-cigarette, or combustible product are worse or better than each other because they're all subject to the same plain packaging. The inability to get the message out about what is a truly reduced risk product, allowed to carry, for example, the FDA statements, whether it's on a snus or an IQOS and other products, makes it very confusing for the consumer. If we took all four of those domains, we would have four powerful means of trying to work together to get people to switch from the known toxic, damaging effects of combustibles to lower risk products.
Derek and Patricia, thanks for those answers. In fact, we have a couple of questions coming through two from Africa, one from India, and I would like to read them one after the other because that will kind of focus our minds on how we can take some of the learnings from the Western world and ensure that access to safer nicotine is not denied to the nearly to the 80% of the current tobacco users globally. So if I may read the first question from Isaac Ogunkola from Nigeria, I believe. One of the fantastic features, he says, of e-cigarettes is the appealing part. It gives smokers the feel of holding a cigarette. But there are still 3 A's limiting factors. These A's are accessibility, availability, and affordability. How can LMICs, which is low and middle income countries, overcome these factors? So this is one question. If I may finish the other two first, and then we come back to the answers around the panel, please. One from India, from Professor Rajesh Sharan, is about market forces and revenue make tobacco an attractive commodity for industries as well as governments. And Patricia, you have touched upon that, especially in LMICs. Nonetheless, the decline in tobacco consumption is happening. Why then industries and governments in LMICs are so rigid about changing gear and moving from tobacco to harm reduction products? And one final one, if I may, please, from Joseph Magero in Kenya, Africa. How can policies protect young people without diminishing the ability of safer nicotine alternatives to help adult smokers transition away from more harmful combustible cigarettes? So just wanted to put these questions together so that we can start addressing them one after the other. Who wants to go first, please? Derek, please.
Yeah, I think these are some of the most important questions, particularly because 80% of the users of tobacco products are in low middle income countries. The level of innovation for new products, the level of innovation for cessation products at the price point of those countries for harm reduction products remains low. That's exactly the raison d'etre for creating the foundation. And if you read Navin Kumar's paper in the journal, you'll see the size of the gap in science and research. Without that, we won't make the needed progress. Secondly, I think they're also speaking to the fact that we need local innovation to develop products that are priced at the affordability level of those countries. How we do that, I would say, should be through the tried and tested ways of addressing market failures, namely bringing together private and public partners to think about how you build an alliance for innovation for low middle income countries. Clearly, the numbers justify having such an approach in India, explicitly for India, and in many parts of Africa, explicitly for Africa. Counted against this are the Bloomberg Foundation funded, I'm sorry to keep talking about it, Union campaign, the International Union of Lung Disease and Tuberculosis, previously called, now the Union, has explicitly called for bans on all forms of harm reduction, particularly e-cigarettes and heated tobacco products in low middle income countries, using the rationale that it's too confusing for them to be able to deal with these things, a real patronizing approach, and leaving them to continue with the combustible cigarettes and the toxic smokeless products as a better alternative to harm reduction. I think this should be exposed as a deeply cynical, unethical approach by a US-based philanthropy that should not be listened to by governments. Unfortunately, it is, because they've got so many other issues on the agenda to tackle that they'll take the expertise coming from a US-based philanthropy. The reality is that we know that across many parts of Africa and Asia, the smokers, the users of smokeless tobacco products, are voting by trying to find products in the market, trying to innovate themselves. We could and should be doing substantially more to make sure that that 80% of the world using combustibles and toxic products actually have access to those affordable products that are made, developed for the market. And let me give you one last, it's a very simple example, which you know all too well, Sud, and that is the fact that smokeless tobacco products in India explain why we have the highest levels of oral cancer in the world. Something that is not new. We've known it for a century, yet the action on doing something still lags. The FDA decision on General Snus shows that you can have a smokeless tobacco product that actually brings the oral cancer risk down to zero. The question I have is, how do we find the innovation to use that very product to adapt it to the Indian palate, the Indian desire, and in the process, eradicate oral cancer? That is sitting right in front of us. If it just takes organization and a little bit more support from the government, and we could do it.
Thank you.
If I may add, Derek, it also takes the willingness to disregard the, outright ban clearly in FCTC against speaking with the industry. I cannot emphasize enough that the industry needs to be part of the solution. Yes, ideally, those results and those solutions would be provided by organizations completely unaffiliated with the industry, but the reality is that who will have the know-how and the resources and sometimes the trademark or the patent on a particular product to be able to sell it in a particular country is going to be whoever the owner of that patent or trademark or product is. They cannot be left out of the discussion.
And is it also the case that at least in the U.S., and even though the U.S. is not an LMIC, there are populations within the U.S., mentally ill and other disadvantaged groups who have very low income and yet who are addicted to cigarettes. And given that a lot of the retail price of cigarettes is the taxation portion, then the differential taxation strategy that you were discussing before, Patricia, and could potentially make these products, reduced risk products, more economical. And certainly from just a physical point of view, a cigarette wastes about 9/10 of its material by going up in smoke in the room. The more innovative non-combustible products use the nicotine very efficiently. Not that nicotine is the major cost of goods necessarily, but there are ways to make these products affordable, I think, with innovation, and certainly the oral products that Derek is mentioning can be. If I might comment on one of the other questions about the metric of tobacco consumption in a country, we have to be mindful of the fact that, at least with cigarettes, one can have a reduction in the amount of tobacco sold, but not necessarily reduced amounts of smoking, because the way in which an individual cigarette is smoked is highly variable. And as the price of cigarettes goes up, smokers will tend to puff more intensively, inhale deeper, and extract more nicotine, but also, unfortunately, more toxic substances from the cigarettes. So it's hard to make a one-to-one association between tobacco consumption and a disease risk.
Just a quick comment on affordability, and I will bring an analogy about smartphones. When in the 90s the smartphones were delivered to the market, the cost was phenomenal. Now we see a lot of immigrants coming to Sicily, for example, and they all have smartphones. That means that over a certain period of time, we will have people, we will have the affordability of the products. And affordability of the product can be also driven by endeavors, local endeavors, for example, having local manufacturing places in Africa or Indonesia or India. And I agree entirely with Patricia. I mean, the industry cannot be left over. It's part of the stakeholding discussion.
Derek, please.
Yeah, I just on that point Ricardo and Patricia raised about the role of industry. You know, I think it's interesting because we accept in the US the fact that the industry engages with the FDA on the science, advances in the science, and they accept that has to happen, and that is the only way forward. And I believe other countries should be following the way the FDA engages with industry and believes that they're able to address the conflicts of interest. It's kind of accepted here, so why would it not be accepted anywhere else? Particularly since a big difference between the US and most of the developing countries is that they are home to state monopolies, where the government itself has between 100 and 20% of the ownership of the very tobacco company they say they officially don't talk to. Well, they own the thing. And whether it's a case of China, Vietnam, Thailand, where there's 100% ownership of the tobacco company, they are part of the government. And how they deal with the fact, on the one hand, that they have to address the health consequences, and the other, they have to reap the benefits of the profits for the coffers of the government and for development in the country, is a complex contradiction very well outlined by Daniel Milan in a report that he just put out from Trinity College in the last couple of days. I'd urge people to take a look at it, because the only way out of that dilemma of an inherent conflict for governments who control 50% of the world's cigarette supply, 50% are produced by state monopolies. The only way out of the dilemma that we can think of is for them to accelerate entry into harm reduction so they can maintain some of the profitability while dropping the considerable health costs of using combustible cigarettes.
Derek, thank you so much. And what I'm going to do now, I'm just mindful of the time, and I wish this could last forever. All of us would. But we have quite a few very good questions, which I want to read out. And if I may request the panel to use some of the questions and in their closing statement, answer a question specifically, or answer this question, which I'm posing to you, which is the Conference of Parties, the 9th meeting of the Conference of Parties happens next year in November in the Netherlands. And what would be your message to the Conference of Parties? So with that one question in mind and some of the other questions coming through the panel, if I may read those questions and then ask the panel to go one after the other to answer whichever they want to answer and however they want to do it. So some very interesting statements from Andrew Thompson to Derek. Do you think nicotine THR corrective statements inserted in cigarette packs would help? Another question from Jeannie Cameron is regarding FCTC Article 4.2b, which obligates the FCTC's 181 parties to take measures to protect all persons from exposure to tobacco smoke. And she asks further, why do we let Article 5.3 have so much resonance and not pick up on this, which has equal standing and obligations? A slightly different question, more in the science of nicotine, and Jared, you may want to touch upon it, please, is from Norbert Zelatron-Schmidt, which is about the synergy of nicotine with MAOI, so MAO inhibitors. And nicotine combined with MAO inhibitors naturally occurring in tobacco smoke has shown to be vastly enhancing addictiveness in animal studies. Now, mind you, these questions cover a whole range of issues. So if we cannot address and answer them today, I'm sure our audience will understand it and we'll have more opportunity for taking these up in the future. One specific question to Professor Pelosa by Barbara Menity is, in your opinion, is it a problem for part of the medical community, the fact that smokers self-administer the tools like e-cigarette? I mean, do they fear that smokers get out of medical control? So you can see a range of very, very important points being touched upon: consumer behavior, the science of nicotine, but also some of the existing framework within the FCTC and how the industry and other stakeholder groups address it at the moment or should be addressing. So may I start with Jed to answer and then we go around? Thanks.
Thank you. I'd like to address the question about other constituents in tobacco or tobacco smoke that might have synergistic or additive effects with nicotine. And that's been an area I've been interested in for many years. Monoamine oxidase inhibitors are one set of components, which, as the questioner rightly points out, animal data suggest that they may potentiate the dependence-inducing effects of nicotine. There are also what are called the minor tobacco alkaloids, other nicotine-like substances in tobacco that may interact with nicotine. There are over 7,000 constituents in tobacco smoke, and we are actually, as part of our research program funded by the Foundation for a Smoke-Free World, we are actually looking at the importance of some of those other constituents in regard to how they might promote addiction and how they may open new avenues for treatment. Because if there are other constituents acting on different systems in the brain, then that gives a target to intervene either in the with a replacement strategy or a blockade strategy. So it's an underexplored area, but it's clearly important that there are other things besides just nicotine alone. And so far, the research on electronic cigarettes, I think, suggests that while they do sustain addiction to an extent, that it appears to be less than cigarette smoke. And so that might also be due to the absence of some of these other compounds in tobacco.
Ricardo, do you want to go next? And then Patricia, and then Derek, you can summarize with the call to COP maybe?
Yeah, sure. I would like to answer that question about the self-medication issue, because I think it's very important. It brings and takes me to another level. I don't really think most of the medical community would fear that. Actually, most of the general practitioners will be relieved not to have to deal with smokers, quite frankly. For them, it's a frustrating business, it's a waste of their time. And don't forget the UK experience at the National Centre for Smoking Cessation and Training. Under that framework, they actually promote the prescription of free electronic cigarettes for people needing them. I have only concern for the US colleagues, where, you know, pharma industry has been governing the smoking cessation landscape. And I think there is a risk that people with an interest in prescribing smoking cessation drugs will lose part of their power, which is attached to the prescription plans of smoking cessation drugs. In terms of message to COP, I really think it's very important that the politician will start and try and understand that we cannot abandon people that cannot quit by conventional measures. I mean, the fact that they relapse is being clearly stated by Jed, by Derek, and by many other researchers all around the world. But it's our mission now, with all these alternatives in our hands, that they are less risky than combustible cigarettes. We cannot abandon these people that they really want to quit, and they cannot quit otherwise.
No, thank you, Ricardo. That's a very powerful message, and I'm sure, and I hope really that it is heard and listened to by the parties when they meet next year, between now and then, and even after that. Patricia?
Yes, thank you. So the most important thing that COP can accomplish this year is to take into account the advances of science, as well as the advances or the innovation in products, and have a candid and unbiased discussion about, and try to quantify the potential benefits of communicating and incorporating those products in a reasonable regulatory system, and move away from the alarmistic recommendations that are based on, the many unknowns. There are always going to be unknowns, but there's also a lot of clarity as to potential benefits. And I would say this should really be the direction towards which COP pivots, a true acknowledgement of harm reduction potential, as opposed to the quit or die and what can we do to prevent demand. And in fact, in demand, not mistakenly include these products, because clearly there is going to have to be a transition period when, one should choose obviously a less harmful product than smoking over a period of time. And maybe 40 years from now, after we've examined, the benefits or the situation, at population level, if these products, the harm reduction products, are used more widely, then we can evaluate, or then COP or any successing body can evaluate, is there value in fact trying to have people quit nicotine altogether. I feel that regulators and COP and everyone who unfortunately has the power, because let me emphasize it, regulation is the single most powerful tool to stir history in one direction or another in terms of harm reduction. So again, COP and all these other folks that have that kind of power to clearly dictate that direction of history really should re-examine their positions right now and take this approach where again we have to work in phases and not simply emphasize just or lump together the harm reduction products into the diminishing of demand reduction, because they do not belong in the same bucket, if you wish, with the most harmful products.
Jed, do you want to chip in, and then we go to Derek after that, please?
Sure. Yeah, I think it would be very interesting if it were possible to put on the agenda an explicit investigation of the role of bias in interpreting data, because I think that's the single biggest impediment to some of these points of potential progress is the cognitive bias that results from mistrust of some sources of information and then trust put in other sources. One need only look at the political domain to see how people can come to entirely different conclusions based on leaders that they trust versus those that they do not trust. And so having some forum where experts who are universally trusted can provide a more objective evaluation, for example, of the fact that nicotine does not cause cancer and expose some of the myths, but then also maybe illustrate how people have selectively interpreted data in a way that they wouldn't if they were looking at another field of science, to try to teach people how, we are all susceptible to bias, but in this field, bias has played such a strong role in preventing the truth from really being disseminated.
Well, thank you so much, both Patricia and Jed, for those thoughts. If I may request Derek to sum up his thoughts on how we go into COP, but also any other questions he wants to answer.
Thanks, Ed. Andrew, I'll get back to you about package inserts about nicotine. I do think that the messenger matters, and it speaks to Jed's point. I think the tobacco company teaching people about that nicotine's not a good thing is probably not going to be received with the openness that it could if it came from a medical group. But I think there's some ideas there. So first, let's remember one thing, that we have well over a year before COP9. Let's double down on our work. Make sure that we actually use this year, an extra year, to put on the table substantially more clinical trials than we have currently on whether e-cigarettes and harm reduction products truly work. Having just a few is not good enough. People really need to accelerate whatever is your research plan now, your work plan, to double, triple the speed and focus explicitly on what you think will have the biggest impact in the agenda leading up to the COP9 process. And we as a foundation will be doing the same and look for ideas. For the actual, as the lead up to the agenda, what I would hope we will see, we certainly need to put some energy into the harm reduction language being in a definition but not being operationalized anywhere throughout the text. And I think the two things we would hope to have in the COP9 session would be an updated, serious discussion around the science along the lines Patricia mentioned. Where are we? What are the levels of uncertainty? Take the type of graphics I've been working on, the modeling many colleagues have been working on, and think about a couple of country-specific scenarios of what if we were actually able to accelerate the change? What would it do for death and disease? Remembering that tobacco sits at the core of the achievement or non-achievement of the Sustainable Development Goals related to health, particularly 3.4. And we are wildly off target on those. That should be the focus in terms of harm reduction. We should also start the discussion around what does it mean to regulate proportionate to risk in practical terms? How would the text actually adapt to that where it actually addresses pricing, flavors, communication strategy, and nicotine? Interestingly, nicotine gets virtually no attention in the Framework Convention. And I think this is the time to look through the text and start thinking about how should it be represented to actually reflect what our current knowledge is. Secondly, the area of cessation, which WHO, by their own accounts, acknowledge has been moving way too slowly, particularly in low middle income countries. Why can't we actually make a commitment that by COP9, we will have an alliance to actually accelerate cessation products in low middle income countries in the same way as we have one addressing vaccines in low middle income countries? That's eminently feasible and is something which would actually have a positive impact, particularly given that WHO has now re-embraced the fact that pharmaceutical approaches to ending smoking actually are acceptable after many years of dismissing it. Thirdly, the trends on women and smoking, particularly in Eastern Central Europe and Latin America, are going in absolutely the wrong direction. One of the papers by Ali Solomon highlights the fact there are many countries in the world where lung cancer death rates today exceed breast cancer death rates in women by far, and they're getting worse. And that women under the age of 40 in many countries across Eastern Central Europe are smoking at equivalent rate to men, meaning that we are going to see a massive increase in the tobacco-related death rates of women and men. And there's no outrage. Putting the fact that gender and the role and the importance of women into the core of the agenda is absolutely needed. The text says, acknowledging the alarming increase in smoking among women. Well, yes, they've been observing that now for 15 years. It's time to move from alarm to action. And then finally, I would say, well, just last two, nothing can happen without money. And unless the Framework Convention Secretariat and the COP9 team is willing to accept the fact that we are seeing a rather steep decline in development aid in the area of global health, except related to pandemic preparedness and humanitarian support, a lot of the progress being made today will actually be eroded fast. An explicit focus on what do we need money for? How much money do we need? The most important question, how would we allocate it? Who's going to raise the money is needed both for the national and the international agenda. And finally, let's not forget that we have started to see the turning point on the decline in demand for leaf tobacco. The consequence of that is going to be seen over the next few years increasingly, particularly in the southern African countries like Malawi, Tanzania, Zimbabwe, Mozambique. We need to have an explicit strategy to take Article 17 and stop just saying it's very interesting, we'll watch it, but invest in the transformation of the economies that have become too dependent on tobacco that they're now undermining their long-term food security. Those are some of the things that I would hope will be part of the COP9 agenda.
Well, thank you, Derek, and thank you to the panel for such an amazing discussion. And I wish we had more time. If I may quickly summarize and then say thanks to the audience as well. In summary, tobacco harm reduction, from what we have heard today, is not an industry marketing idea. It originated in the WHO and is based on the clear understanding that nicotine is addictive, but not the one that causes the cancer, the lung disease, and the heart disease associated with tobacco use. This principle was embraced by consumers in the Western world when they found reduced risk alternatives in non-combusted forms of properly manufactured and regulated tobacco and nicotine products. Swedish snus in Sweden, NRT and e-cigarettes in the UK, heated tobacco products in Japan. However, as many have brought up today, access, affordability, and availability of any form of safer nicotine products remains a challenge in LMICs. And even if these problems were solved using innovation, addressing market failures, as Derek mentioned, and overhauling regulations, nicotine illiteracy remains a big stumbling block among all consumers as well as their influencers, including healthcare professionals. So we have barely scratched the surface of the issues neglected by the tobacco control community, such as diversity, development, and today, tobacco harm reduction. We hope to reconvene soon. We want to thank, as the conference organizers, we would like to thank the Foundation for a Smoke-Free World for financially supporting this event. And we hope to reconvene soon to be a constructive yet nagging conscience for all stakeholders in the tobacco world, from public health to corporate entities, to ensure that their actions are accountable and congruous globally. One final thought, I got a lovely message here from none other than Judy Gibson. So I would like to read that as a way to say thanks to the panel and to all who have listened. Judy says that huge thanks to all the members of the panel for a very informative and multifaceted conference. One of the best webinars I've attended, despite now suffering from webinar fatigue. So I totally understand the sentiment, and I really appreciate all of you, some on the East Coast waking up early to do this call, and thanks all for joining this, and hopefully see you all soon. So thank you so much.
Yeah.